Raising awareness in the scientific community is, I think, of the utmost importance. It's really critical that the people that take care of people living with liver disease know this and are able to pick up the signs early, manage the patients accordingly, and refer them to specialized centers once it is clear that ACLF is developing, preferentially before the full-blown ACLF is clearly there. So it's clear that that kind of creating awareness around it in the scientific community, the medical community, the hepatology community, but also all the other disciplines that are involved in the care of these patients, like the intensive care colleagues, the nephrologists, etc. They should all be well aware of the existence of this syndrome and what the guidelines are to manage these patients. How to do it? I mean, there's no one-fits-all solution for that. As with any education, you need a portfolio of things, and some things will work for some people in some specific conditions, and in other educational settings, healthcare settings, you need other tools. I think it's critically important to have that collaboration with all these different specialties and different levels also of healthcare in the system, because it's a very difficult population to help, to treat, and so every little detail can help. Having a team of nurses that has experience with this kind of patients will be helpful, as we know for many other aspects of medicine. If health caregivers have experience and knowledge, the quality of what they do will be superior to people that, although they are sometimes very motivated, but have less experience. And that's a general principle, and it applies even more to difficult situations like ACLF, where, as I said, every little detail counts.
We have a very limited range of treatments that we can offer for these patients, and effectively in intensive care, when we bring them to the ICU, we will give them organ support to address the organs that are involved, and we will seek to identify what the precipitant to the illness has been, and we will try and address that. But sadly, with many people, by the time we meet them in the ICU, they're already too sick for us to see much improvement, at least with the tools we currently have available to us. So there are a number of factors that we consider when we're making treatment decisions about any patient in critical care, and those also apply to patients who have acute-on-chronic liver failure. So we think about the patient's age, their underlying comorbidity, what other illnesses do they have, what's their overall physical state like, what sort of physical reserve have they got, will they be able to tolerate a severe critical illness? And those are considerations for every critically ill patient. But we also then have to think about specific elements of liver failure. How bad is the liver failure? Is there a degree of reversibility? Is this the first time this has happened to a patient? And then we have to think about the number of organ systems that are involved. Is there only one organ system? Is it just the kidneys that we're having to help? Or is it the kidneys, the blood pressure, the respiratory function, the brain function? All these things can happen together. And we make an assessment about the likely outcome of the illness on the basis of all of those factors. So we aim to give intensive care therapies to support all the different organ systems to try and keep things stable. And there are two principal complications that we're looking out for in these patients, and they would be the development of infection, which can often worsen organ failures, or other complications, particularly bleeding from the gastrointestinal tract. So we have a whole series of measures that we use to try and prevent both those things from happening.
The problem with ACLF is the severe degrees of inflammation, the multi-system organ failure that drives this short-term mortality. And in fact, patients may become too sick for liver transplant too fast. The decision to transplant a patient with acute-on-chronic liver failure is really best undertaken by multidisciplinary, interprofessional teams with lots of experience in this realm, who have access to early critical care services and then also experience with post-transplant pathways to best support the patient that you have decided to transplant with acute-on-chronic liver failure. Certainly we know that patients with lower grade ACLF, ACLF1, are likely to have better survival after liver transplant and in fact use lower healthcare resource or lower rates of healthcare resource utilization post-transplant than those with higher grade acute-on-chronic liver failure. So the priorities for treatment not only identify patients who are at risk for ACLF, but to identify patients with early ACLF So I think this prompts an important question regarding futility of transplant and how we determine how sick is too sick for transplant, aside from the liver failure. And that post-transplant outcomes change as we see increasing amounts of organ failures and an increase in the severity of specific organ failures, particularly for patients with respiratory failure and circulatory failure. Patients with acute-on-chronic liver failure who are transplanted are at higher risk of bacterial infections post-transplant that raise the risk of that 1 year post-transplant mortality and raise our concern for the futility of transplant in higher grade ACLF patients.
On the translational side, we have contributed first describing that systemic inflammation is the major driver of ACLF development in patients with decompensated cirrhosis. We performed a study 5 years ago in which demonstrated that the levels of cytokines, which are markers of inflammation, were even higher in patients with ACLF than in patients with sepsis. The reason why these patients have this so intense systemic inflammation is not properly known at present, but we think it is because the presence of pumps and dumps in the circulation of these patients. The abundance of pumps in the circulation of these patients is secondary to the impaired permeability in the intestine. That's why it's so important the gut failure in these patients, because it allows the translocation of these pathogen-derived pumps that stimulate the immune cells. On the other hand, we have an increased production of DAMs. DAMs are damaging, molecules that are released during the damaging of the cells. We need to understand how the immune system works in these patients. So the immune system is the most important factor involved in the development of organ failures, especially those that are extrahepatic. We need to find a way to get a balance between the immune system, especially a balance between the innate immune system and the adaptive immune system. So we need to not only fight the inflammation, but also immunosuppression. For example, this low count of lymphocytes.
We need treatment addressing pathophysiology of the syndrome. We know that systemic inflammation is a hallmark of the syndrome, but we don't know exactly what is the impact of systemic inflammation on organ function. We have to understand which is the prevalent mechanism, and this is important to identify a clear target for novel therapies. Immune deficiency is a hallmark also of ACLF, and immune deficiency explains why these patients are prone to develop infection, bacterial infection, fungal infection, etc. Therefore, we have to understand which mechanisms are underpinning immune deficiency if we want to target directly immune deficiency in this patient. And the other point is that if you develop drug against systemic inflammation, you should take care of not worsening immune deficiency. AFCLIF is expert for running large prospective observational studies among patients with acutely decompensated cirrhosis. The first achievement was the first description of an evidence-based definition of ACLF and diagnostic criteria. Another achievement was a relatively comprehensive description of the cellular molecular landscape associated with ACLF, because we already performed a lot of omics studies, and now we have a relatively clear view of the landscape. We should increase the awareness of stakeholders. Stakeholders include pharma and policymakers, the people who are deciding in the US, in Europe, everywhere, the public health policy. Therefore, we have a lot of work to do.